الرحمن الرحيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. Good evening, everybody. I'm Mohammed Al-Sunaid. I'm a nephrologist at King Faisal Specialist Hospital and Research Center in Riyadh, and I'm the Vice President of Saudi Society of Nephrology and Transplantation. So, on behalf of the Society, I would like to welcome all of you and to thank you as well for joining one of the Society's scientific activity. I would like to take this opportunity for us to thank our speaker and moderator for accepting the Society invitation. So thank you for joining us this evening, both of you. This webinar, as you know, is organized by the Society of Nephrology and Transplantation and sponsored by Novo Nordisk company. So I'd like to thank our colleague from Novo Nordisk for the generous support to this webinar. And also, I will not forget to thank our technical support to this webinar, our colleague from Event Group company for providing the technical support to this webinar. As you notice in the flyer, dear audience and participant, this webinar is accredited by Saudi Commission for Health Specialty for 2 CME hours. So there's just a few announcements I would like to share with you before we start. The 2 CME hours will be entered the participant account who wrote the registration number in the registration form at the beginning. This will probably be taken 2 to 3 weeks to be entered in their account. So please, you don't need to place your registration number in the chat during the presentation. So it will be entered automatic, as I mentioned. And also, you have to be very clear to everybody, there is no attendance certificate will be issued or sent to any of the participants. So this will be, as I mentioned, entered automatic CME hours to their account. And last, also is very important that if you have any question related to the presentation, so please do not hesitate to write it in the Q&A site in the screen. And our moderator at the end of the presentation will share it with our speaker and to answer all your question and inquiry. So without further ado, I wish you all to enjoy this scientific activity. And now I will hand the mic to our moderator, Dr. Talal Fadel. Talal, mic is yours.
Thank you so much, Dr. Mohammed. And I would like to welcome you all to this important topic. As you know, diabetic kidney disease is probably the most common kidney disease and most common cause of end-stage kidney disease. And this topic affects multiple specialties. So without further ado, I will pass the mic to Professor Vlado Perkovic. So Professor Vlado Perkovic is a professor of internal medicine and nephrology from the University of New South Wales in Sydney, Australia. He has a great interest in diabetic kidney disease with multiple peer-reviewed publications. And the hope is that we all can benefit from this talk. And we will, inshallah, without further ado, we'll start. The mic is yours, Prof. Perkovic.
Thank you very much, Dr. Al-Fadel. Hopefully you can hear me okay. And thank you for the opportunity to speak to you this evening. I'm very pleased to be here with you and look forward to discussing this really important topic. These are my disclosures. Please note that I was the principal investigator and the chairman of the steering committee for the FLOW trial, which will form the core of what we're going to talk about today. And I've also been involved in leading a number of other trials in diabetic kidney disease, funded by many of the companies that we'll be talking about, including Novo Nordisk. So just before we start, a reminder of why this topic is so important. A reminder that the number of people with type 2 diabetes in particular is growing dramatically still around the world. And I know, having recently visited Saudi Arabia, how much of an issue this is in your country. In 2021, there were more than 500 million people around the world with type 2 diabetes. By 2045, in the next 2 decades, it's estimated that that number will grow by a further 46% to over 780 million people. So a huge number of people around the world, really a tsunami of type 2 diabetes. And of course, we know that CKD is a very common complication of diabetes, particularly type 2 diabetes, where about 40% of people will end up with chronic kidney disease and all the implications of that diagnosis. And as a result, at least in part, in substantial part, to the growth in the number of people with type 2 diabetes, we're seeing very large numbers now of people with chronic kidney disease worldwide. 844 million people estimated to have chronic kidney disease in 2017. More people with CKD than there are with type 2 diabetes. This is not a race that we want to win, but unfortunately at the moment, kidney disease is in plague proportions around the world. I know that at the moment Saudi Arabia has a relatively young population, which perhaps means that the rates aren't as high as some other places in the world, but with the high rates of type 2 diabetes, this number is going to continue to grow. And not only is the number of people with type 2 diabetes high and growing, CKD high and growing, but actually the death rate from this condition has increased over the last 30 years by about 40%, such that CKD is rapidly rising as a cause of death in the global statistics, having risen from 19th to 12th from 2013 and to 2017, and predicted to become the 5th leading cause of death around the world by 2040. And that, that's a big problem, and one that whilst we've seen improvements, for example, in heart disease, in some cancers and a range of other conditions in both prevalence and mortality rate, that hasn't been true for people with CKD. So we've got a lot of work to do. And if we look at individual countries, for example, the US, 39 million people estimated to have CKD in 2017 and 85,000 deaths resulting from it. So a massive problem. And that growing prevalence of CKD in total has also driven a progressive increase in the rates of the most severe forms of the disease, end-stage kidney disease, requiring either dialysis or transplantation. And I like to use this US data because it goes back such a long way. And if we have a look at 1980, which is some 45 years ago, there was about 50,000 people in the US who required dialysis for end-stage kidney disease. That number has grown from 50,000 then to over 800,000 today. So, approaching 1 million people with end-stage kidney disease. And the other important thing is if you have a look at the changes from year to year on this graph, it grew from every single year from 1980 to 2019. There was a progressive increase. And again, this contrasts over the same period of time with the rates, for example, of ischemic heart disease, which have fallen by about 2/3, related partly to the better treatments that are available, but also partly to better management of risk factors. And in contrast, in the area of kidney disease, we've really failed to date to even just control, let alone reduce the burden of this really important condition. And the burden of this condition is substantial. We know that having chronic kidney disease increases the risk of kidney failure, unsurprisingly. And there on the left-hand side, we see the relationship between two different markers of kidney disease, the two important ones, and the risk of kidney failure. On the x-axis, we have eGFR, and you can see where the red arrow is at an eGFR of 60. Once eGFR falls below 60, the risk of end-stage kidney disease increases exponentially. Look at that y-axis. It goes up to an 8,000-fold increase. And for any level of eGFR, the level of albuminuria, shown here by the different coloured lines, blue being normoalbuminuria, green being low levels of albuminuria or microalbuminuria as we commonly call it, and red being high levels of albuminuria or macroalbuminuria. So for every level of kidney function, if you have high levels of albuminuria as well, that risk is further increased. The two accelerate each other and are really multiplicative. So a very high risk of kidney failure with reducing kidney function, but also a very high risk of cardiovascular disease, shown in the middle panel, and death due to any cause. So as kidney function falls, the risk of all of these conditions increases. As albuminuria increases, the risk increases, and particularly if you have both, the risk is extremely high. So finding ways to protect kidney function, particularly in people with type 2 diabetes, becomes a really important goal. And preventing the incidence of kidney failure requiring dialysis is perhaps the most important goal at all. On this graph, we see some data regarding the risk of death over 5 years for people who are diagnosed with kidney failure, started on long-term dialysis, compared to people with a range of common cancers. And you can see that at 5 years, just a little over half of people are still alive. So almost half of people have died within 5 years if they started on dialysis. And that mortality rate is equivalent to someone diagnosed with leukemia. It's worse than having colorectal cancer or non-Hodgkin's lymphoma or bladder cancer. So it highlights that the presence of kidney failure really does shorten life dramatically. It also dramatically reduces quality of life, and it's an expensive condition to treat. So clearly the preference is for all of us to be able to prevent kidney failure and treat kidney disease early. The challenge has been really, until the last 5 or 6 years, we didn't have many tools available to us. And indeed, up until 2019, the only thing we had available to us was renin-angiotensin system blockers, shown on the top left there. The top, very far left panel is the RENAL trial, which looked at losartan compared to placebo, and the IDNT trial next to it looked at the angiotensin receptor blocker irbesartan compared to either amlodipine or placebo. And both trials showed that renin-angiotensin system blockade significantly reduced the risk of developing a composite kidney outcome and reduced the risk of kidney failure. So this has been guideline-based therapy, protective therapy for people with diabetes and kidney disease for over 25 years now. In 2019, and over the couple of years following that, I had the privilege of presenting the Credence trial, which showed that canagliflozin, an SGLT2 inhibitor, reduced the risk of composite kidney outcomes and kidney failure further in people already treated with renin-angiotensin system blockade, if they had type 2 diabetes and kidney disease. And those results were confirmed and extended by the DAPA-CKD and the EMPA-Kidney trial subsequently, showing that SGLT2 inhibitors further reduce the risk of composite kidney outcomes and of kidney failure in people with diabetes and kidney disease. And they also reduce the risk of cardiovascular complications, particularly heart failure, and of death. So these are now additional foundational therapies for people with type 2 diabetes. And then most recently, in the top right panel there, we had the Fidelio DKD trial, which looked at the non-steroidal mineralocorticoid receptor antagonist finerenone compared to placebo, and showed that this drug also protected kidney function in people with diabetic kidney disease. So we now have 3 classes of treatment available to us that can help to reduce the risk of adverse outcomes in people with diabetic kidney disease. So that's great progress, but the challenge we have is, if we have a look in each of these trials, the residual risk, in other words, the persistent risk of adverse kidney outcomes in people even who are treated with these powerfully effective drugs, remained high, highlighting the need for additional promising therapies that can help to protect the kidney and cardiovascular system in people with diabetes and kidney disease. This led to great interest in the GLP-1 receptor agonists, a class of drugs developed for the treatment of diabetes and for weight loss in people who are obese, and tested in a number of cardiovascular outcome trials that were summarised in the meta-analysis I've got on the slide here. In the top half of the slide, we look at the cardiovascular trials. These were not kidney trials. These were trials looking at the effects of these drugs on cardiovascular outcomes in particular, and showed that they were protective against cardiovascular outcomes. But when we looked at a composite kidney outcome, a broad composite, there was a suggestion that the class of drugs might also protect the kidney. The problem with the top half of the figure here is that it includes the outcome of developing macroalbuminuria, which is not an outcome that is really relevant to patients, and it's not an outcome that, as nephrologists, we're confident is necessarily clinically important. So when we exclude that development of macroalbuminuria from that outcome and look at just the composite of kidney failure, losing half of your kidney function, or dying due to kidney disease, which is what's done in the bottom half of the graph, we can see there's still a suggestion that there might be benefit, the hazard ratio of 0.86, but the results are no longer statistically significant. So based on this meta-analysis, it was unclear whether GLP-1 receptor agonists protected the kidney. In addition, in the meta-analysis, the authors looked at whether the use of GLP-1 receptor agonists prevented cardiovascular events in people with CKD, in people with an EGFR below 60 mils per minute on the bottom half of this graph, compared to those with preserved kidney function on the top half. You can see in those with preserved kidney function, there was a very clear 13% reduction in the risk of cardiovascular events. But in those who had kidney disease, there was a suggestion again of benefit, but once again, it was not statistically significant. So the value of GLP-1 receptor agonists in people who had kidney disease was uncertain based on the totality of the existing data when these meta-analyses were done. And that led us to design the FLOW trial, which I'm going to be mainly talking about today. The FLOW trial is a double-blind placebo-controlled trial that included people with type 2 diabetes and chronic kidney disease, defined by an EGFR between 25 and 50 and different thresholds of albuminuria depending on the EGFR level, as summarised on the left-hand side of the slide. The patients had to be already receiving a RAS inhibitor, and we recruited 3,500 of these patients and randomised them to either semaglutide 1 milligram subcutaneously weekly, the diabetes dose of Ozempic, or matching placebo in the traditional approach where the dose was increased over a period of 8 weeks. We designed the study to continue until over 850 of those patients had one of the composite primary outcomes, the development of end-stage kidney disease, losing half or more of their kidney function, or dying due to either cardiovascular or kidney disease. And we expected this would take 2 to 3 years to occur during follow-up. But indeed, when 2/3 of those events had occurred, an independent data monitoring committee that was looking at the results for us told us that, in fact, the trial had already shown clear benefits and it would be unethical to continue the trial. So the trial was actually stopped early because of this overwhelming benefit. The primary outcome, as I've said, was the onset of a composite kidney outcome, including kidney failure, the development of the loss of at least half of kidney function, or death due to kidney disease or cardiovascular disease. We also included 3 confirmatory secondary outcomes using a statistical technique that meant that we could test them robustly in order if we showed benefit for the primary outcome. So if the primary outcome was significantly reduced, we could look at the annual rate of EGFR decline as the first secondary outcome. If that was benefited, we could then look at time to cardiovascular events as the second secondary outcome. And if that was significantly reduced, we could then look at time to all-cause death as a tertiary outcome. We also had a number of additional supportive and tertiary outcomes. The trial was fully recruited, and this slide summarises the baseline characteristics of the participants. They, on average, were a little over 65 years old, and 2/3 were male. They were quite overweight, with an average body mass index of 32 kilogram per metre squared, and they had long-standing type 2 diabetes of over 15 years duration on average, with average hemoglobin A1C of 7.8%. Kidney function was reduced with a mean EGFR of 47 mils per minute, and the patients on average had very high levels of albuminuria, a median UACR of 500 plus milligrams per gram. The average blood pressure was about 140 on 80, and about 20% of the patients had either an MI or stroke or heart failure in the past. Almost all of the patients were receiving a RAS inhibitor, and because the trial was initiated before the SGLT2 inhibitor data from the Credence and other trials was reported, many of the patients weren't receiving an SGLT2 inhibitor at baseline, but almost 16% were, and that number increased progressively over the course of the trial. So let's have a look at the results of the trial. This is what happened to the patients in the placebo arm over the average follow-up, which was about 2.6 years. And you can see that almost a quarter of the patients in the placebo arm had the primary outcome, either developed kidney failure, lost half of their kidney function, or died due to cardiovascular or kidney disease. This was a very high-risk population. In the patients who were randomized to semaglutide, that rate was lower, 18.7%, which resulted in a highly statistically significant 24% reduction in the risk of the composite kidney outcome with semaglutide compared to placebo. And this resulted in a number needed to treat at 3 years of about 20 patients to prevent one composite primary outcome. So a very significant and clinically important benefit. When we have a look at the individual components of the primary outcome, as shown here, you can see the outcomes that I described as being part of that primary on the left-hand side. We see quite consistent findings. The benefits were similar across each of the components of the individual parts of the primary outcome. But of course, the trial was not powered to detect effects on the individual components, but rather on the composite as a whole. And this gives us reassurance that the benefits were similar for the kidney components and the cardiovascular death components of that primary outcome. We did a large number of subgroup analyses, and the main message from those is that the results were consistent across different levels of kidney function, different levels of albuminuria, the presence or absence of different types of cardiovascular disease, and a range of other parameters. We'll talk a little bit about some of the background therapies towards the end of this presentation, but very consistent findings across pretty much all of the 17 subgroup analyses that we did as part of the trial and that we'd pre-specified. So having shown benefit for the primary outcome, we could move on and look formally and robustly at the first of the secondary outcomes, which was total EGFR slope, or if you like, the rate of loss of kidney function over time. And this figure shows what happened to the patients randomized to the placebo arm. They, on average, lost 3.36 mils per minute of kidney function per year. And in the semaglutide arm, we saw an initial dip and then stabilization. They lost a slower rate of kidney function, 2.19 mils per minute per year, which led to a difference in EGFR slope of 1.16 mils per minute per year. So statistically significant slower rate of loss of kidney function in people randomized to semaglutide compared to those randomized to placebo. Because EGFR is typically calculated with serum creatinine, which in turn is generated from muscle in the body, and semaglutide causes weight loss, some of which may be muscle loss. There was concern as to whether that difference in kidney function might be partly related to loss of muscle rather than actual protection of the kidney. So we also looked at EGFR calculated using a different blood marker, cystatin C, which is not dependent on muscle or is not affected by weight loss. And what we found was almost identical findings on kidney function, giving us reassurance that the benefits that we observed were indeed benefits on the kidney and not just related to weight loss. So now, having shown benefit for the first of the secondary outcomes, we could look at the second of those, which is the effects on major cardiovascular events. As shown here, we've shown benefit for the primary outcome, for the first and the secondary outcomes, eGFR slope, so we can now look at major cardiovascular events. And this is what happened to the patients from the cardiovascular point of view. Again, a very high-risk population, 14% of them had a cardiovascular event in 2.6 years of average follow-up, whereas in the semaglutide arm, that rate was 12%. So again, a statistically significant 18% reduction in the risk of cardiovascular events with semaglutide in this population. And when we look at the individual components of that composite cardiovascular outcome, we see consistent effects on CV death and non-fatal MI, but in this trial, we didn't see any clear effect on the risk of non-fatal stroke. So having shown benefit now for two of the composite outcomes, we could move on, two of the secondary outcomes, we can move on and look at the third and final pre-specified secondary outcome, which was the effects on all-cause death due to any cause. And again, this is a very high-risk population. 1 in 6 of the randomized patients died in 2.6 years of average follow-up. People who have diabetes and kidney disease are at very high risk of death. But when we randomized patients to semaglutide, those people had a lower rate of death, 12.8%. So again, a statistically significant 20% reduction in the risk due to death, risk of death due to any cause, or if you like, on average, a prolongation of life in people treated with semaglutide compared to placebo. So in fact, in our trial, we showed benefits not only for the composite primary outcome, but in a statistically robust and clinically important way, additional protective effects on rate of loss of kidney function, cardiovascular events, and death due to any cause. And the numbers needed to treat are summarised here. Over 3 years, 20 patients would need to be treated to prevent one primary outcome, 45 to prevent one cardiovascular outcome, and 39 to prevent one person from dying due to any cause. And it's important to note these numbers are comparable to widely used preventative therapies like, for example, the benefits of statins for hyperlipidemia. One of the other outcomes that was of interest was heart failure. We didn't pre-specify this as one of the outcomes. When we designed the study, the conventional thinking was that SGLT2 inhibitors were more effective for heart failure and that GLP-1 receptor agonists might be better for major cardiovascular events, atherosclerotic events, and for kidney failure, but perhaps had lesser effects on heart failure. But in fact, that conventional wisdom has been challenged both by the FLOW trial and a number of other trials subsequently. In our trial, we looked at the effects on a composite of either hospitalisation for heart failure or the development of death due to cardiovascular disease, and we found, again, a highly statistically significant 27% lower risk of this outcome in people treated with semaglutide compared to those treated with placebo in the trial. And when we looked at the individual components, we saw almost identical effects on both the risk of heart failure and the risk of cardiovascular death. And when we looked at this further in more detail and broke the patients down by whether they had heart failure at baseline, shown in the solid lines here, or those patients who didn't have heart failure, in the patients who didn't have heart failure, the development of new onset heart failure was reduced. And in those who did have heart failure, the development of subsequent heart failure events, hospitalisation or death, was also reduced to an almost identical degree. So it didn't matter whether people had heart failure or not, they got protection against heart failure moving forward. What about safety? These are the summary of the safety data. In total, the risk of serious adverse events ended up being lower in the semaglutide arm compared to the placebo arm by about 4%, as shown here. But the risk of adverse events that led to the drug being discontinued was higher in the semaglutide arm than the placebo arm. And again, this was primarily due to a higher risk of gastrointestinal side effects leading to study discontinuation, a common side effect of semaglutide that we're aware of and other agents in this class, but one that can be managed in the majority of patients. And we've already talked about the beneficial effects on death due to any cause. So when we now put this data in the context of the previous trials and update the meta-analysis I showed you at the start with the addition of FLOW, the composite kidney outcome that was not clearly reduced in the original meta-analysis is now clearly and significantly reduced by a total of 18% on average with GLP-1 receptor agonists with consistent effects across the various trials. And indeed, when we now pull out the risk of kidney failure separately, we see a separately statistically significant 16% reduction in the risk of kidney failure alone in people with type 2 diabetes treated with these agents. So confirming the importance of the kidney protective effects. So to summarise what we found in the trial overall, there was a reduction in the risk of major kidney outcomes, in major cardiovascular events, in cardiovascular and all-cause mortality, and probably in heart failure as a post-hoc analysis. And that's led to semaglutide now being proposed to be the fourth pillar of standard care for people with diabetes and CKD. As described at the beginning of the talk, we've already had evidence for renin-angiotensin system blockade, protecting the kidney. More recently, SGLT2 inhibitors and the mineralocorticoid receptor antagonist finerenone have been added to that list. And now with the FLOW trial, we also have benefit with semaglutide. So these four treatments are now considered the standard of care for people with diabetes and kidney disease. And one of the questions that was often asked was, do they work in combination? If someone's already on an SGLT2 inhibitor, for example, will they get the same benefit from semaglutide compared to someone who's not on an SGLT2 inhibitor? And we can look at this by looking at subgroup analyses from the FLOW trial of people who were receiving an SGLT2 inhibitor compared to those who weren't. And what we'd like to see is that the beneficial effects, that has the risk ratio reduction, is the same in both subgroups. And we can do the same for people on mineralocorticoid receptor antagonists. And particularly given the data that's already shown clear kidney benefits for SGLT2 inhibitors summarised in the SMART-C meta-analysis on this slide for people both with diabetes and without diabetes. So we did that analysis in the relatively small number of people who were treated with SGLT2 inhibitors, and this is the subgroup data for people who were and were not treated with SGLT2 inhibitors at baseline. On the left-hand side, we see people who were not receiving SGLT2 inhibitors, and the treatment effect there is a 27% risk reduction, highly statistically significant, with a very large number of patients. You can see the vast majority of patients were not receiving an SGLT2 inhibitor at baseline, and these people were also at higher risk, which provides more statistical power to test whether or not there is an effect. In the people who were who were receiving an SGLT2 inhibitor on the right-hand side, you can see that the number of events was very small. There were only about 100 events, and there was no clear effect identified for this composite outcome, perhaps due to the reduced study power. But at the bottom, we have the P for interaction, which tests and says, are the results significantly different for people who were and were not receiving an SGLT2 inhibitor at baseline? And the statistical answer is no, they were not significantly different. The results are potentially consistent, but really there was inadequate power to test with this analysis. So one way to increase the power to look at the effects in this subgroup is to look at the effects on kidney function, which is what we did. And here's the effects on eGFR slope. And in this case, you can see that in people who were not receiving an SGLT2 inhibitor on the left-hand side, and in those who were receiving an SGLT2 inhibitor on the right, there was evidence of consistent benefits protecting kidney function in both subgroups. So that tells us that even if someone's already on an SGLT2 inhibitor, if we add a GLP-1 receptor agonist, we'll protect their kidney function further. Not only that, but when we look at the benefits on cardiovascular events, we can see, once again, the results are clearly consistent in people who were and were not receiving an SGLT2 inhibitor with very similar hazard ratios and a P for interaction, which was clearly not significant. So they will additionally get benefits in reduction of cardiovascular events and additional benefits in the reduction of death due to any cause with, again, very consistent benefits. So the use of a GLP-1 receptor agonist, even in people who are already receiving an SGLT2 inhibitor, provides additional benefits for patients. And this question's also been studied in the other way. If someone's already on GLP-1 receptor agonists, do they get additional benefit if you start them on an SGLT2 inhibitor? And there's many more trials with much more statistical power available here in a SMART-C collaboration. Almost 80,000 people have been randomized to clinical trials. And even in people who were using a GLP-1 receptor agonist already that produced identical benefits to those people who are not on a GLP-1 receptor agonist. So the two treatments appear to be independent of each other, and the benefits are additive. You get greater benefits by using the two drugs together than by either drug alone. So what about the other class of agents, the mineralocorticoid receptor antagonists, and particularly the drug finerenone, which has been shown to be beneficial for kidney outcomes as well in people with diabetes and kidney disease? Does semaglutide have the same sort of benefit in people receiving a mineralocorticoid receptor antagonist? And in the flow trial, we were able to look at this in subgroup analysis. And here are the data. You can see that the hazard ratios at the top suggest benefit for both people who are receiving an MRA and those who are not. The p-value for interaction at the bottom is 0.12, so not statistically significantly different. Consistent benefits regardless of the use of MRAs. So these two drugs, again, have additive benefits to each other on the kidney. And again, when we looked at eGFR slope, consistent benefits regardless of whether people were or were not using a mineralocorticoid receptor antagonist at baseline. So despite the limited power, there was no evidence of differences in the effects for kidney CVM mortality outcomes. The benefits appear to be consistent and additive for these classes of agents, not only for the kidney, but also for cardiovascular events and all-cause mortality. And this strongly supports the multi-pillared approach and suggests to get optimal kidney benefit, we should be trying to get our patients on all four pillars of therapy because semaglutide is additionally beneficial regardless of the use of SGLT2 inhibitors or mineralocorticoid receptor antagonists. Why is that important? Well, it's important because the magnitude of benefits we can get with the drugs is very substantial. If we have a look here at this analysis that was published by Dr. Brendan Newen last year, where he looked at the classes on the effects on kidney outcomes of each of those three classes of therapy, SGLT2 inhibitors in the top line, GLP-1 receptor agonist and mineralocorticoid receptor antagonists in the next two lines, and then looked at the effects of various combinations. I'll draw your attention to the bottom line here, which is what treatment effect might be expected if people use all three of these treatments compared to people who don't use any of them, SGLT2 inhibitor and a GLP-1 receptor agonist and an MRA. And the answer is we might expect almost 60% lower risk of composite kidney outcomes and potentially kidney failure in people treated with all three treatments compared to those who don't get any. This just highlights the dramatic reductions that might be possible if we can get these treatments to our patients. And furthermore, if we look at the effects on death due to any cause, and again, I'll draw your attention just to the bottom line here, which shows that the combination of all three treatments can reduce the risk of death in people with diabetes and kidney disease by 1/3. So profoundly effective treatments. And again, to summarize and finish up here, a reminder that kidney disease is very common and is associated with very bad outcomes, particularly as it becomes more severe. We now have highly effective therapies that not only reduce the risk of composite kidney outcomes and kidney failure, but also MI, stroke, and death. They prolong life. And semaglutide is now established as a protective therapy in people with type 2 diabetes and CKD as one of the four pillars of therapy, which collectively can dramatically reduce the risk of kidney failure, but also cardiovascular events and death. And our major challenge now is that low awareness of kidney disease and access to care are the barriers. It's no longer the knowledge about treatments or their availability. We have the treatments available. We know they work. We really need to effectively implement them now to improve outcomes for our patients with type 2 diabetes and chronic kidney disease. And on that note, I'll thank you very much for your attention. I'm very happy to take any questions. Thank you very much.
Thank you so much, Prof. Lado, for this elegant talk. We've got a few number of questions. I think some of them they have been answered during your talk. Some we probably will touch on. So the first one that I can see is what's the optimal dose of semaglutide in managing CKD with diabetic kidney disease?
Yeah, it's a good question. And the short answer is we don't know what the optimal dose is. We know that the worst dose is zero. But in the trial in semaglutide, we used the 1 milligram subcutaneously weekly, the diabetes treatment dose of semaglutide. We haven't studied the higher dose, the Wegovy dose of 2.4 milligrams weekly, to know whether that has greater benefits. We know it is associated with greater side effects, and people with kidney disease tend to have side effects related to therapy more commonly than those people who don't have kidney disease. There is, I think, a need for us to study that dose before we go recommending it more broadly. But for the moment, the 1 milligram dose is clearly beneficial, and I would recommend people try and use that dose wherever possible.
Another interesting question that we got is what's the best practice? Which of the treatments would you start with first?
Yeah.
RAS blockade, SGL2 inhibitors for beginning, and then adding additional treatments, or would you start them simultaneously?
Yeah, it's a good question, and it's a major topic of debate at the moment around the world, actually, not just in kidney disease, but also in cardiovascular disease and in diabetes. There are two schools of thought here. One school of thought that trialists like me will generally follow is to say, well, you should do what was done in the trials. So in the trials, we required people to be on RAS blockade, so starting them on an angiotensin receptor blocker or an ACE inhibitor up front is important. But one of the other things that we know is that we often get tired as clinicians, but also as patients, if it takes too long to start these treatments and people get sick of just constantly coming back and starting a new treatment every time. There is some advantage, for example, to starting multiple treatments at the same time, particularly things like renin-angiotensin system blockade and SGLT2 inhibitors, which are generally very well tolerated, and apart from perhaps a little bit of hypotension, which is generally resolvable very quickly, have very few side effects when they're started. So there's a push to start multiple treatments earlier. And indeed, there's been a trial of two different approaches in people with heart failure called the STRONG-HF trial, where people were randomized to either rapid initiation of multi-drug therapy in heart failure, which is similar to that we see in kidney disease, over a period of 4 to 6 weeks, compared to just treat patients as you normally would. And that rapid approach reduced the risk of patients being hospitalized for heart failure or dying. So it had clinical benefits for patients if they were started rapidly on these treatments. So I think the answer ultimately is that we need to tailor it a little bit to individual patients. But what we shouldn't do is dawdle. We shouldn't take our time to start these treatments. We need to get the patients on as many of these proven protective therapies as we can, as quickly as we can, once they're diagnosed with diabetes and kidney disease.
The other question that we've been getting is any specific side effects that you'd watch for? We know that the optic nerve damage or affecting the GLP-1s affecting the optic nerve was starting to emerge recently in the literature. Any specific populations or precautions that you would advise for, and how to follow up for such complications?
Yeah, that's an important question. The major sort of side effect that we saw was actually the gastrointestinal side effects, nausea, in some patients vomiting or alteration of bowel habit. And we know that this occurs in 10 to 20% of people treated with these agents. And in most patients, it resolves over time. So just slowing down the dose increase or even a dose reduction for a period of time will generally allow those symptoms to settle, and then the dose can be subsequently increased in most patients again, or even maintained at a lower dose if that's all the patient tolerates. I think that's still better than not getting any of the drug. So that's the most common side effect. There's been a lot of discussion about the ocular effects of GLP-1 receptor agonists. When the first trials were done, they were generally done in people with very poorly controlled diabetes, and we saw rapid reductions in hemoglobin A1C in those patients. And patients who had proliferative retinopathy sometimes had a worsening, likely to be related to that rapid improvement in hemoglobin A1C. In the subsequent trials, including in FLOW, people who had unstable proliferative retinopathy were actually excluded. So they're a patient population in whom we should be cautious, and getting, if someone's got evidence of proliferative retinopathy, that should be treated first before they're started on a GLP-1 receptor agonist. There's been questions about the risk of other types of eye disease, particularly ischemic optic neuropathies more recently, and some observational data suggesting a possible association. We didn't see that in the FLOW trial. The rates of ocular side effects were collected very carefully and proactively in the trial. And when we did that, the rates were actually pretty much identical across the two arms. There was a higher rate of reporting of ocular side effects in people who were on the randomized to semaglutide, but when we looked at that in detail, that may have been a bit of a reporting bias. It's not clear. So, whether or not that's a real side effect, I think is still open to some debate. But I think in general, being careful in people with eye disease and monitoring ocular function in people with commenced on these agents is sensible. Really, beyond those two, we didn't see any differences in the side effect profile between the two arms, either in this trial or collectively in the trials when they're looked at in composite, in meta-analyses. So it's a remarkably safe treatment, and with a remarkably broad array of benefits, not only on the kidney but on the heart, on all-cause mortality, and now, of course, being studied for conditions like dementia as well. And it'll be interesting to see whether there may turn out to be benefits for this class of agents, even for conditions like dementia. We just don't have that data yet.
Excellent. One of the interesting questions that we have here is if we say that someone has benefited from semaglutide, they've lost weight, is there a carry-on effect if they stop the treatment? Have you noticed any of that?
Yeah, it's a good call. We haven't looked at that specifically in the FLOW trial for the people who discontinued therapy, and it's a little bit difficult because we lose randomization because the discontinuation rates were different across the two arms, so we're not comparing apples and apples. But the available data suggests that it's likely that there's perhaps some residual benefit. This has been studied, for example, in SGLT2 inhibitors from the EMPA kidney trial, but that some of the benefit is lost. So really, I think the treatment should be considered as a lifelong protective therapy. I think that's where people are likely to receive the benefit. It's not just something they have for a period of time and can then stop. If people can tolerate it, they should stay on this treatment long term.
Is there any preference from your side to the 1 milligram per week or the 2.4, the Wegovy?
So I think for the kidney protective effects, they've only been shown with the 1 milligram per week. The higher dose has additional benefits in terms of glycemic control, but especially weight reduction, and I guess can be used for those purposes. But we don't have data showing additional kidney benefits, so I don't think that should be a consideration necessarily. It's also a question that often comes up about whether this is a class effect or a drug-specific effect for semaglutide. My view is that it's likely to be a class effect. We're likely to see these benefits with other drugs in the class, but really the only drug they've been shown for to date is semaglutide. We're still waiting on data, for example, for tirzepatide, and some of the newer drugs that are being developed in the class double and triple blockers appear promising, but I'm very cautious about using them until we've got proper randomized controlled trial data in this population, and that doesn't currently exist.
Excellent. Any GFR level that you would start considering holding the medication? And would you? There is another question: is have you used this in dialysis, or do you expect it to be used in dialysis in the dialysis population?
Yeah, so in our trial, we continued the drug regardless of eGFR and the commencement of dialysis, and we didn't require patients to stop it. And we didn't see any particular issues in patients who had very low levels of eGFR. We randomized patients down to an EGFR of 25, but people continued on the drug with EGFR levels much below that without really any concern. There are some small studies that have also been done in dialysis patients showing that the drugs are generally well tolerated, similar side effect profiles, and similar benefits for glycemic control and weight. But we don't have so much data on, for example, clinical outcomes. The available data suggests that these drugs can also be useful for those purposes in people with reduced, even lower levels of kidney function and on dialysis. But we should just be a little bit careful because we don't have as much data as we might like.
And do you expect we will start seeing trials, or if they're not ongoing, in people with other types of kidney disease, non-diabetic kidney disease?
Yeah, absolutely. And we saw that with the SGLT2 inhibitors, for example, where we initially studied them in type 2 diabetes and were really quite surprised by the magnitude of the benefit that was observed, which caused excitement and caused us to look at them also in people with non-diabetic kidney disease. When we first started trials like DAPA-CKD, there was a lot of debate. Some people felt it was unethical to even do a trial in that population, but we did the trials and we showed not only that it was ethical, but it was profoundly beneficial in people with non-diabetic kidney disease. With GLP-1 receptor agonists, again, we're not entirely sure of what the mechanism of effect is. Glycemic control doesn't appear to be part of it, and people with well-controlled diabetes could be enrolled in the FLOW trial and had similar benefits. So it doesn't appear to be related to the glucose-lowering effect, which suggests it might also be beneficial in people with non-diabetic kidney disease. Some studies along those lines are underway at the moment. There's one trial really which has looked at this in any sort of detail, the SELECT trial, which was a trial of high-dose semaglutide, 2.4 milligrams weekly, the weight loss dose, in people with obesity who did not have diabetes. And in those patients, there were relatively few kidney events, but the protective effects on the kidney appeared to be very consistent with those that we saw in FLOW, suggesting that perhaps this class of drugs might also be beneficial in non-diabetic kidney disease. But I think we need more data before we can say that for certain.
Excellent. I'll give my fellow panelists if anyone wants to ask any questions. Dr. Mohammed Snaid, I see that you've turned your mic on.
Yeah. No, actually, just because if you're done with the question, before we just conclude this webinar, really, we enjoy the talk very much. So on behalf of the society, I would like to thank all participants for the really active participation and engagement in this webinar. And I would like to share with all of you that the number of participants in this webinar is more than 2,200 participants during this presentation. So this reflects how much this important topic to the community. So thank you for the presentation. Again, I would like to thank our speaker, Prof. Berkovic, and our moderator, Dr. Talal, for again accepting the society invitation. And also I'd like again to thank our sponsor company, Novo Nordisk, for their sponsoring this event, and also the event group for the excellent technical support that we have this tonight. So we wish to see you again, Prof. Berkovic, and physically here in Riyadh in one of our upcoming conference symposium, as well as the future webinar. We'll keep in touch for sure. And for all those participants, we also would like to say that thank you for your participation, and we are looking forward for your future participation in our upcoming webinar and scientific activities. So please check our society website so we can check when our next scientific activity. Again, thank you all, and good night, and wish you, Prof.